Okay, welcome everyone, and this is the third lecture from a series of lectures we have started for basics of radiology and going more towards advanced imaging. Okay, today we are going to discuss basic anatomy of perennial sinuses, orbits, and ear. So these are very vast topics. So I will be discussing only a little bit of basic anatomy on imaging and all those clinical aspects, all those structures which are important from clinical point of view. The ear is a very long topic. It needs a completely separate lecture for it, but I will be touching, as I said, only the basics. So starting from perineal sciences, these are very important in face or head and neck imaging because a lot of pathologies are associated with it, benign versus malignant, and they mimic at times. So, what are paranasal sinuses? These are air-containing cavities in many bones of the skull. So, they are different sinuses we have, and clinically they are divided into two groups: anterior group and posterior group. In radiological language, you are not going to use the anterior paranasal sinuses or posterior paranasal sinuses. You have to name them anatomically according to the location and extent of the disease which is being involved for it. So anterior group basically involves the maxillary, frontal, and anterior middle ethmoid air cells. Okay, let me make it a full screen. So maxillary, frontal, anterior, middle ethmoid air cells. They are anterior group and they open in the middle meatus. Posterior groups include two things, which are posterior ethmoid sinuses, and they open in the superior meatus, and the sphenoid sinus, which is a little bit uh, more at the back than posterior ethmoid sinuses. They open into sphenoethmoid recess. So basically, if you want to remember, just remember two things: the middle meatus, which drains all of these superior meatus, posterior ethmoid, and sphenoid from sphenoethmoid recess. Now, all the sinuses are not present at birth. The maxillary and ethmoid sinuses are usually present there, and they're large enough to be significant. So you need to remember that in pediatric age group, especially before 5, only ethmoid and maxillary sinuses are there, and rhabdomyosarcomas or other tumors are usually associated with these. Radiologically, maxillary sinuses can be identified at 4 to 5 months on all the imaging modalities. Later on, then ethmoid sinuses, then sphenoid at the age of 4, and frontal sinuses at the age of 6. So, this can be a potential question in exams of radiology. The first one to appear after birth, and the last one. So frontals are at the one extreme of 6 years. They appear the most late. So beginning with the maxillary sinuses, these were also known as antrum of Highmore. And these are the largest paranasal sinuses which occupy the maxillary bone. So here is a diagrammatic representation of all the paranasal sinuses basically. That's frontal portion and superior one, that's frontal sinus, bilateral, and ethmoid sinuses. These are the two maxillary sinuses which rest within the body of the maxillary bone, and the sphenoid of the posterior one, you can't see them. We have this nasal cavity. They are pyramidal in shape, with base towards the lateral wall of the nose and apex towards the zygomatic process. Now, this is the lateral wall of the nose, and this towards side thing is the apex, this pointed end, and that's the base, which is towards the zygomatic process. So that's basically the pyramid, how it is formed, and it has a capacity of 15 ml on average in a human body. But important thing is to know the relation of it. Anteriorly is the facial surface of maxillary bone and the soft tissue of the cheek. So whenever there's some anterior cellulitis thing or infection going on, anterior wall is the most one to be affected, and cheek will be the area you need to look for clinically. Posteriorly, very very important, infratemporal and pterygopalatine fossa. Pterygopalatine fossa is one of the most favorite structures for anatomists, and usually it is not seen. It's an arbitrary space in anatomy on clinical grounds, but on imaging we can see pterygopalatine space in fossa because it contains pterygopalatine ganglion, and pathologies which are going to involve the posterior aspect of maxilla or maxillary sinus, they usually affect pterygopalatine fossa and its contents, uh, and gives very specific clinical signs and symptoms. So we need to tell properly whether pterygopalatine fossa is involved or not. Medial wall is bimetal inferior turbinate. What turbinates are, that's the past of the nose basically. Floor is by alveolar and palatine process of maxilla. It's related to all molar tooth and sometimes to the premolar if it is bigger enough. So in reporting, we need to make sure that during reporting for maxillary tumors or any other disease process which is involving the floor, we need to comment on alveolar arch, superior one, teeth, and hard palate. Roof, obviously, it's formed by the orbit and it's traversed by the infraorbital nerves and vessels. When they are involved, the patient has specific signs and symptoms. Now, how these structures are related. This is a coronal diagrammatic representation. These are the two orbits, right and left one. Now this is maxillary sinus on the right and left. So let's start from the superior aspect, the last one which I told. So that's the roof of the maxillary sinus, which is formed by the floor of the orbit. Here inferior orbital nerve and vessels are present. So whenever something in the zygoma or maxillary bone or towards the roof of the maxillary sinus, basically the floor of orbit, any orbital pathology can come down to involve the maxilla, or the maxillary pathology can go up to the orbit. So that will give a very bacular imaging appearances. You are able to tell which is the epicenter, whether it's orbital pathology going down or maxillary pathology going up. So the wall will be destructed, thinned out, involved or not involved, or it's just a soft tissue. Medially, this is nasal area. So this is the medial wall of the maxillary sinus, that's the draining infundibulum of it. So it is related to nose. Whenever there is something going within the maxillary sinus, it's going to obstruct this area and infect this. Or if there's a nasal pathology which is going on there, it will obstruct this path, and there will be secondary retention of the screening, secretions, and all that stuff. So a floor of the maxillary sinus is formed by this arch, that's hard palate, and that's the alveolar arch, and here we can see the root of the tooth, molar or premolar. So whenever there is something going down, we need to comment on the alveolar arch or hard palate. The anterior and posterior relations are shown in scan. So laterally is the sarcoma. I'm sorry. These things become important, the walls, superior, inferior, medial, lateral, and posterior as well, because in the cases of trauma, the Leafoot classification of facial trauma, paranemic trauma, when we'll study about it. So that classification and extent of trauma, you need to tell more easily if you know all these relations and structures, and you need to tell all the details, because the complex facial fractures, they need a separate maintenance. Okay, on this is axial CT bone window This anterior part is showing the anterior aspect of the maxilla and the nasal bone. So we can see the soft tissue of the cheek and the muscles of face over it, making the anterior one. And posteriorly, we have this infratemporal fossa here, and this is the pterygopalatine fossa. Now, it is formed just behind the base of skull structures, the posterior wall of the maxilla, and this slit-like opening or an area just below the floor of orbit. So if the orbit is going down here, just imagine posteriorly going down this place and maxillary sinus going posteriorly here. So that's something, a space bilaterally where pterygopalatine fossa or recess it. If you look carefully, there's something in it. That is pterygopalatine ganglion. Moving on to frontal sinuses. These are paired sinuses like maxillary one and deep to inner and outer tip of frontal bone. So they have their own importance being in the frontal lobe, frontal bone, sorry, and important to know its relations because of spread of disease into the cranium. It drains through the frontal recess to the middle meatus by the osteomeatal complex, so it's one of the anterior group sinuses, and they can be absent one or both sides and very large extending into orbital plate, which makes it clinically relevant because roof of orbit pathologies can mimic this one. Now, relations of frontal sinus, as we saw in the maxillary one. Anteriorly, there's skin over the forehead. Now, this is the coronal and sagittal views of frontal sinuses. Mind you, one thing, whenever you're looking on maxillary sinus, frontal sinus, or any other sinuses, coronals and axils should be your sequence of choices, except frontal sinus, which is more better seen in sagittal one as well. So that's the coronal one, and frontal is the sagittal one. In the sagittal, we can see this is nose, that's the brain interiorly. So that's frontal bone. This is the anterior table or the outer table, and that's the posterior inner table, the red one. So posterior to this is the brain parenchyma, anterior to this is the skin. So we have anteriorly the skin and forehead. Posteriorly, we have meninges and frontal lobe of the brain. Inferiorly, we have orbit and its content. How we can see that? We can see more anteriorly here. This is these are anterior ethmoid cells in the roof of the orbit formed by the frontal bone, and then zygoma starts. So here somewhere, this pinkish thing is the frontal sinus. Here it lies. So floor of this is formed by half by the roof of the orbit. So in these are ethmoids, so that will be just draining area of it. So frontal recess, where it is, that's this one. It's a pathway of the frontal sinus, usually in the floor, drain into middle meatus or into the ethmoid infundibulum, depending upon its location, more anterior, more posterior, or more medial. In 62%, mostly it's in the middle meatus, and if it is in the ethmoid infundibulum, 38%, it's like in both posterior and anterior groups. So how it is clinically important. Now, all the infections or tumors or any other pathology which is within the frontal bone that is involving the frontal sinus can go into the brain, either extraaxially or interaxially. That means it can invade into the brain parenchyma, but can just involve the meninges, and that can mimic the signs of meningioma or something intracranial symptoms, not only just the bone. Osteosteoma is one of the most commonest benign tumors which occur within the front bone and can possibly, if it is bigger enough, it could cause mass effect. Alternatively, we have brain pathologies which can come into the frontal sinus. Usually, in radiology exams, do put a case of fungal infection of frontal sinus, which is going into the brain, causing abscess formation, and at times dural sinus thrombosis as well. Ethmoid sinuses. Ethmoid sinuses, these are very thin walled air cavities, and they're lateral masses of the ethmoid bone. The ethmoid bone is one in the midline, and on two sides we have ethmoid sinuses. And they're further divided into anterior, polar, or posterior group. The polar cells are also called the middle ethmoid cells. Basically, we are not able to differentiate between the middle, anterior, posterior. Basically, the middle ones on imaging because they are merged together in a row from anterior to posterior, posterior to anterior, whatever you say. But this classification is more for ENT people. Now, the anterior ethmoids, they are approximately 11 anterior air cells which drain into an ethmoid and fundibulum or fundonasal duct. So basically, I will show you the drainage pathway, how these sinuses do drain. Buller cells are the middle ones. They are less than 3, so we usually don't see on imaging uh, or able to differentiate. Actually, we do see open into the ethmoid infundibulum and then posterior group. These are approximately 7 posterior cells which drain by a single orifice into the superior meatus. So the posterior group is basically the main posterior group of paranasal sinuses, and anterior and the middle one which are merged together, they form the anterior one. Now, their relations are very, very important. Ethmoid sinuses are, in the middle of something, like maxillary sinus on both sides, frontal at the above, sphenoid posteriorly, and they are like in the middle of it, at the exactly at the middle of the base. So any pathology coming from above, from sides, from posteriorly, that is going to involve ethmoid sinuses, and they have very, very, very thin perceptible walls, and they are easily destructed, especially fungal sinusitis or inverted papillomas or stuff like that. When it comes, they bulge into the ethmoid sinuses and disrupt them, cause thinning of their walls. Or they are already very thin, so when there's thinning and crusting of the walls, it gets very difficult, but it remains important radiologically to tell their involvement and extent of the disease. So roof is by anterior cranial fossa. 1 inches of brain form the important relation here. So basically, anterior cranial fossa base is the one which is forming the roof of the ethmoid sinuses. Floor is by maxillary sinus and hiatus amylonaris. This is important. What is hiatus amylonaris? You should be and need to be able to identify whole of the hiatus amylonaris. I will show you what it is. Lateral wall is by lamina perputia of the orbit. Very, very important, lamina perputia. Uh, if tumors, pathology, any other stuff going on, and it's disrupting the lamina perputia, a radiologist must tell it is gone, because that means that gives an ancillary feature that the orbit is going to be involved or already involved by the disease process. Medially, the nasal cavity and medial plate of the ethmoid, basically nasal, it's in the midline structure. Now here, optic nerve form an important relationship with the posterior ethmoids and it is at risk during the ethmoid surgery. This thing is important for ENT surgeons when they are going to operate upon and they get a Paranasal sinus CT. You must tell the relationship of optic nerve with the posterior ethmoids. Sphenoid sinuses. Now it occupies the body of sphenoid. So when we talk about sphenoid, it's like almost in the mid of at the junction of anterior middle cranial fossa, so it's a little bit more back. And usually patients with signs and symptoms of headache, like deep inside, they have pathologies of sphenoid sinus, even sphenoid, simple sphenoid sinusitis, routine because like the name, that can mimic features of severe headache, and patient do present like that. There's nothing in the brain, and whenever sphenoid bone pathologies are there or tumors or hyperplasia or stuff, uh, they can go into the sphenoid sinus. Sphenoid sinus has very, very important, importance because of its location. There are two, right and left. Obviously, they're really symmetrical and are separated by a thin boring septums. This thing is important to know because they are not symmetrical. One can be very small, the other can be very large, and that can deceive you by its so large size. Osteomeatal sphenoid is the upper part of the anterior wall drain into sphenoethmoids, one of the posterior ones. Average size is 2 to 2 into 2 centimeters, not necessarily. Now, the draining or pneumatization of sphenoid sinus is very variable. At times, it's as small as its conchal one. It's 5% of the whole sphenoid pneumatization. That means this can be this very small, a very, very little one sphenoid sinus. And we can may think of it's aquatic or it's like hypoplastic. Basically, that's the clivus bone, it's pituitary or sella, and here is the sphenoid sinus, just rest here. That's the most commonest one, B type, which is presellar, like in front of the sella or pituitary gland. This is sinus, and that's the opening from where it is draining down clivus. Now, this part, which is most commonest, like 67% we see is post-seller. Pre-seller is usually seen on one side. The both can overlap actually. The pre-seller and post-seller, like right one or left one, they can be there together. Now, this post-seller means that it is crossing the sala, the boundaries of sala going behind it. So whenever this thing happens, like large sinus and disease present over here in this part can mimic like uh, features of pituitary. There's mass effect on pituitary or involvement of pituitary, or base of skull cellulitis involvement by sphenoid sinusitis and all that area that can also mimic um, brain symptoms or sphenoid symptoms. Now, when we look into the sphenoid sinus at coronal images, this is one of the diagrammatic representations. Its importance, comes very clearly. How, because of its location, there are so many structures around, and it is involving so many things. The pathology is related to it. Now, this is sphenoid sinus on the right side, and that's the big one, sphenoid sinus on the left side. There's a thin septum which is dividing those, and there's the base of the brain skull. Now, at just the middle of it, we have superiorly the pituitary gland, just as we saw this one. This pituitary one, it's just a coronal section over here. So now pituitary is there, sphenoid sinuses are below. This blue structure is cavernous sinus, and the red dots are internal carotid arteries. So cavernous sinus, internal carotid arteries, these are important here. And these are a row of nerves: oculomotor nerve, trochlear nerve, abductor nerve, and fifth nerve to the veins. So third, fourth, fifth, and sixth. All these cranial nerves, they are like in a row in relation to cavernous sinus. And above we have this optic chiasma. Now, which is part of the second cranial nerve, or like confluence of those optic nerves. Now, all the cranial nerves, venous, cavernous sinus, and carotid artery, these structures are very important because they get involved whenever there is a pathology from the sides of the brain, from below to the sphenoid sinus, or pituitary masses. The big adenomas, they're going to involve cavernous sinus, they can cause mass effect on it, they can engage it, go into the sphenoid sinus, or the sphenoid pathologies go up. Whenever these structures are important because patients usually present with cranial nerve palsy symptoms, or in cases of cavernous sinus thrombosis, there are different sinus symptoms. If carotid artery is involved, it's luminous, involved. There will be lack of flow void and MR. You can't see enhancement of it. Aneurysms of carotid artery can cause mass effect and optic chiasm pathologies. So, sphenoid sinus has this importance because of its location and associated structures in the surroundings. Moving on a little bit, in the nose, this diagram is showing you a sagittal cut section of the face. Here we have the frontal sinus, and you can see a little bit of idea from here. The most posterior is the sphenoid sinus here, and then pituitary is there. Now the lateral wall of the nose, this is nose, this is floor, the hard palate, the soft palate, these are teeth and tongue. Now in the nose we have these outpouchings, or you can say prominences. These are called conchae. These are three projections: superior one, this is a smaller one, middle one, and inferior one. These are soft tissue projections, mucosal thickenings, and they are held in place by the turbinate, the bony turbinates, middle, inferior, and superior turbinates, and around them these are the conchae. These are called nasal conchae. Now between them there are spaces, these slit-like spaces. These are called meatai or meatuses. So superior, middle, and inferior meatus. Now since the start I'm saying like inferior meatus, middle meatus, superior meatus. The middle meatus is the one where the anterior group of the paranasal sinuses drain all the secretions. The inferior one is the one between the two, the hard palate and this inferior concha, where obviously that lower ones or the anterior ones secrete, and in the sphenoid recess where the posterior ones. Now, the report of the report of paranasal sinuses FES protocol is incomplete. The report of paranasal sinuses is incomplete until unless you comment on the osteomeatal complex. What it is, it's a common channel that link the frontal sinus, anterior medial meatus and maxillary to the middle meatus. Basically, it is the anterior group of paranasal sinuses which are drained through this, and the whole structure-like thing is called the osteomeatal complex. Can you guys hear me? Because I had a little bit of interruption in between. Somebody can just write in chat yes or no. And can you see the slides? Or if I will continue, if someone can just pop up, that's fine. It is composed of 5 structures. Yes, somebody just said it. Yes, okay, thank you. Maxillary antrum and maxillary ostium, sorry. That is the draining channel of maxillary sinus. What it is, I will show you all these structures one by one. Infundibulum, it's a common channel which drain the maxillary sinus and ethmoids to hiatus amylorinaris, which is second time I'm telling you what this is very important. Ethmoid bulla, it's a single layer cell which projects over the hiatus amylorinaris. Again, this is important. Uncinate process. This is a hook-like process. It arises from the posteromedial aspect of nasolacrimal duct and forms the interior boundary of hiatus amylorinaris. So, see, in all these structures, hiatus amylorinaris is the one which has come all over again. So, this is very important. Hiatus amylorinaris, what it is, it's basically a drainage passage. It's like a pathway between the ethmoid bulla superiorly and a free range of uncinate process. Now here we are going to see this one. As I told you before, sagittal, coronal, axial, all the sequences images should be seen. Reformats when you are reporting paranasal sinus, especially sagittal whenever you see a frontal one. Otherwise, it's fine. Now, I will touch it a little bit later. Now, going this diagram first, that's the frontal sinuses. So, sagittal image, we have this nose, this is anteriorly skin and nose, posteriorly this is brain. Now, that's the frontal sinus, and that's the frontal sinus draining pathway. Now secretions from here go in this pathway and drain into this opening. This whole passage is hiatus semilunaris. So it's a continuous passage from where it is draining the frontal sinus. Here, these are the ethmoid ear cells. So these are likely the posterior ones. These are the anterior ones, and that's the sphenoid sinus. Now, what happens is the anterior ethmoid sinuses, they drain into this hiatus semilunaris from this pathway, this one. The frontals are going from this one, and how the maxillary I will show you in the this picture. So hiatus semilunaris is draining this one, and maxillary on the corners I will show you. So this whole passage is draining all the way to the middle meatus. That's the middle meatus. So this opening will open here. That's the inferior turbinate, middle turbinate. That's the bony projection. But basically, that middle meatus will be in relation to this. Now, these sphenoid sinus and posterior ethmoid sinus, these drain together through this opening, this one. If you can see, follow my arrow. This pathway is the draining passage for these. That will drain posteriorly into sphenoethmoid recess or in the inferior turbinate at times. And that's the nasal area. This is hard palate. Okay. Now, a little bit orientation about this. This is orbit and different muscles. The bone is there. It has been taken at the level like a little bit posterior or at the mid of the maxillary sinus. You can say this is the maxillary sinus on the left. That's the right one. Now that's a body of zygoma bone. This is hard palate. In between, that's the ethmoid bone, the crista galli. Now these are ethmoid sinuses, and this is maxillary sinus, and that's maxillary sinus. Now that's the pathway, outflow tract of this one. You can see from this side, I think labeling a little bit hindering to this. Now this path, this one, is the infundibulum, or the area from where the maxillary sinus is gonna drain. So the ostium, this is the opening, ostium of the maxillary sinus. That's the infundibulum, a little bit one. This flip, if you can see, this flip-like thing, that is uncinate process. Now, the uncinate process is like a trap, like epiglottis. It can just close or it can be open. If this is obliterated, the infundibulum is stuck, ostium will close, and things will start accumulating within the maxillary sinus. So secretions will be retained over here, or any other pathology which is involving the ostium or ethmoid sinuses that's going to block this outflow tract. So we have ostium, maxillary sinus ostium, ostium itself, infundibulum, the uncinate process, and hiatus semilunaris. The hiatus semilunaris, we can see this is a long track here. On this section, we can just see this one because that's the anterior ethmoid sinus here. That's the draining part of it into the hiatus semilunaris, this one, and from here the maxillary sinus will drain into this portion, and this static area, that's the one, is the hiatus semilunaris, and it will drain here into the nose, into the middle meatus. That's the middle turbinate and concha. That's the inferior turbinate and concha. You can just see the mucosal thickening if you to get a little bit of idea how hypertrophy or thickening can look like. So that's basically the outflow tract for the anterior group of sinuses. Frontal sinus will drain into it, the anterior ethmoid will drain into it, and that's the way. And maxillary will drain again into it, this one. And posteriorly, obviously, this group will drain over here. So you should be able to trace out the drainage pathway. If the drainage pathway is obstructed, you will find the pathology all the way up. I'm running short of time, but I will go equally important. All these structures are, so just a little bit of anatomy on axial sections at different levels. At the level of anterior ethmoids, or like supralaterally, supromedially, sorry, these orbits are there bilaterally. Here in the medial part, this is the crista galli, the midline structure in the brain. and this is the brain tissue. We have these ethmoid ear cells. These are a group of different ear cells which are there. Now what I wanted to show you is lamina preparatia. This thin line which is making the lateral wall of the ethmoid sinuses is lamina preparatia. If this wall is disrupted, you can see this is orbit, a little bit of fat and the orbital muscle. Here this is lamina preparatia. The pathology is already crossed the boundaries and it's gone into the orbit. We have this anterior ethmoid artery canal as well. At times you can see it, at times you can't. But once lamina preparatia is gone, the story is over. It has infiltrated into the orbit. Posteriorly, you can see this superior orbital fissure at times is involved, mostly by the pathologies back here. Relieving of sphenoid usually not involved by the anterior ethmoid sinuses, though. Um, in anti-ethmoid sinuses, you have to tell whether there is a opacification or not, and lamina preparatia is involved or not. Now, moving a little bit down and posterior, we have these group of posterior ethmoid. Now, you can make out yourself, we can't see the middle ones because they're merged together. Anterior ethmoids and then a posterior ones. Maybe this one is a middle one. We can't really say on imaging. That's the ethmoid bone basically in the midline, and we have anterior and posterior ones on the right, left and right respectively. Now this is sphenoid sinus. You can see the other one can be very small or atretic. That's posterior pituitary gland posteriorly, and dorsum sali is the bony part of that. Now lamina preparatia is coming all the way down here along the posterior wall as well. So this makes it. Sorry, I had a disruption in the connection. Can you guys hear me? Okay. So, beginning again, so lamina preparatia is the one structure you should comment every time when you are reporting the paranasal sinuses. Okay, a little bit moving more at the back, we can down and at the back we can see sphenoid sinuses more clearly here, and now the ethmoid sinuses, they have completely gone, and we can see the draining passages which are the turbinates. So that's that one bone here. Nasal bone is there, but basically that one is going away. Nasolacrimal duct pairs on both sides. It's symmetrical opening here, and we can see the maxillary sinuses more clear, and the pterygopalatine fossa. So basically it's just the back of and base of orbit and the sphenoid maxillary sinus. Sphenoid sinuses lie on the medial to this aspect. Now at this point we are able to see the base of skull foramina, which I have discussed before too in my previous lectures. Now inferior orbital foramen, here it is the floor of the orbit and the roof of maxillary sinus. So basically this foramen is the one which is containing inferior orbital artery and nerve, and this disruption is or its involvement is important to tell. The turbinate hypertrophy or turbinate pathology or any other thing should be reported on coronal images, how they're going to look like. So these are the three sections from anterior to posterior coronal ones. Here these are the orbits, that's the most anterior part, and we see a little bit back where you can see the structures going away. That's the globe basically, and we can see the optic nerve here and the muscles, and posteriorly we can see the nerves are basically gone, just the orbital apex is there, and we can see the sphenoid sinuses and posterior parts. Now this midline structure, this one is crista gali. This is important. This structure, cribriform plate of ethmoid bone, and it has fovea ethmoidalis. The cribriform plate of ethmoid is important because this structure is involved or gone in pathologies where there is a communication between the anterior cranial fossa of the brain, that's brain parenchyma, and the anterior ethmoid sinuses or the nasal cavity. Crista galli and front plate of ethmoid, their involvement in disruption is important. We need to mention clearly they are involved or not. Olfactory bulb is present at just at the base. So olfactory tumors or any pathology related to frontal bone, frontal lobe, like it's herniation of the brain tissue. If these bones are broken down, they will herniate down, or any pathology from the sinuses will go up. They will reach this bony area and they will go up into the brain. Fovea is just a little bit of opening here. Now we can see the turbinates, the ethmoid plate, inferior turbinate is here, middle one somewhere over it should be here, and superiorly above. Now these structures are nasal lacrimal duct. That's what I wanted to show you because that's another training area for the anterior sinuses. Now that's the one I have discussed already before, just to show you that lamina propria is this thin walled structure over here. So this looks like this on coronal images. You can see an axial and coronal both, but coronal is far better. Again, the draining pathway, we can see this is ancillary process, itis and iris, as I told you before. Middle turbinate and meatus, inferior turbinate and meatus. And posteriorly, we can see the middle. Basically, this is turbinate and that's meatus. It's wrongly labeled. That's turbinate and that's meatus. Meatus is the air containing space, and turbinate is the one which is containing bones. These are the concha basically. Turbinates is the bony terminology for that, and the soft tissue projection, that is the concha one. So that's superior, middle, and inferior one. And at this set level of posterior ethmoids and pterygomaxillary fissure, great bowel formula, these are the basic structures of the fissure bone. So going more posteriorly, these are the sphenoid sinuses, and here we can see the base of skull foramina and these fading or going away nasal structures. This slide I just put to show you guys anterior ethmoid, middle one, and posterior one in one go, and the draining areas here, here, and posteriorly. Here we can see the middle and inferior turbinate on lateral images as well, so that you can have an idea like this thing is draining here, somewhere here, this will drain into it as well, and that will drain all the way into the superior, and this one middle turbinates. That's the draining path. Very small areas or the linings which drain these. If there are anything which is disrupting downwards, there will be accumulation of the secretions above into the frontal and ethmoid sinuses, obviously. Now the trick is to differentiate between the retained secretions and true pathology. That will give us idea what is going on. When we'll be discussing the pathologies, we will see MR is the better modality than CT to look for these pathologies at times. CT will help, but basically to differentiate the soft tissue things, MR is better. Now a little bit more about paranasal sinuses, which is important, which you need to mention in your report for sure. There's a term called concha bullosa and the other one is lamellar concha. What these are? It's an aerated turbinate. What does that mean? I will show you it will more clear. Often in the middle turbinate, there's pneumatization and bulb occlusion because concha bullosa. If the only attachment is in the middle turbinate, only the attachment portion is pneumatized, and it's called lamellar concha. Now, if you see, this is inferior turbinate, this bony thing is, and that's this concha here, the middle one, superior one. Now, if you see this picture, the coronal image, we can see the bony projection. There's pneumatization. There's air within this bony area. If you just make expansion in it, If the middle turbinate is aerated like this is not normal. This is called concha bullosa. It has its importance because when the ENT surgeons wants to operate, if it doesn't know there's concha bullosa, they will go in, they will call create a fistula between these areas. So there will be continuous draining and dribbling all the way from here into this area. So this is important to tell that whether this is pneumatized or not. Let me show you this one over here. If you can make up, this is the middle turbinate. That's one. There is no aeration of it. Now here you can see these are pneumatized. So this is called concha bullosa. If only the infundibular part of the draining area, that's lamellar concha, only this portion, not all of it. You can see this infundibular draining part is there, but still we can see the bony projection here and the concha around it. So the attachment portion is pneumatized, it's lamellar concha. Eagerness eye cells. These are another anatomical, all these are anatomical periods. These are normal and you should mention whenever you see these on imaging. The most anterior ethmoid cells, if you come very, very anteriorly here, we can see the frontal bones, frontal bone and frontal sinuses. This portion of anterior ethmoid, with the steric here, X, that's Eagerness eye cell. It's anterior, lateral, inferior to the frontal recess, just below the frontal area, and it directly influences the patency of frontal recess and anterior middle meatus. Now, importance of Eagerness eye cells is for frontal sinuses. Actually, it is part of anterior ethmoid cell, but it has clinical importance for frontal because obstruction of this cell will cause problems for the frontal sinus. Haller cells, these are important. These are also called infraorbital ethmoid cells. Where they are present, they are just below the orbit. This one with the star. This is extramural ethmoidal layer cell extending to the intermedially of the orbital floor. It is present in approximately 20% of the patient. Now, the clinical significance of this, it becomes infected and it has a potential extension into the orbit. At times, just this portion is infected, goes into the orbit, breaching this wall, and rest of the paranasal sinuses are fine. Other thing is it narrows the maxillary osteomeatal. That is the draining part of the maxillary antrum. So it has narrowed a little bit. On this side there is another one. So if that would not have been present, it was a smooth outflow tract. So Heller cells, Eagerness eye cells, concha bullosa, these are the anatomical variants you should need to know. Quickly.